Hello, folks, it's Beth again, and I am doing you a podcast on Chapter 58. We are in NUR 237, Unit 5, and this is our last unit. Yay, yay, yay. I know you're thrilled about that. So, we're going to be talking about disorders of the eyes here, and we need to just talk a little bit about those disorders so you can kind of understand a little bit about it. So the first one there is glaucoma, and that's a fairly common disorder of the eyes. It's a group of diseases that's characterized by the optic nerve damage and, of course, changes in the visual field, and also increased intraocular pressure, IOP. Anything, the ocular pressure, anything greater than 22 millimeters of mercury is what is considered increased intraocular pressure. So, that's going to be an important number for you to remember. So, although glaucoma can occur even with a normal intraocular pressure, but typically you do see an increase in that pressure. And it is one of the leading causes of blindness in our country. Diagnostic tests include the ophthalmoscopic examination of the optic disc. They measure the intraocular pressure, or a tonometry test is done, and also testing of the visual fields is done as well, because that's how part of their vision that's affected with glaucoma. So the most common type of glaucoma is the open angle glaucoma. And again, you'll see the increased intraocular pressure with that. The cause is not known, as a lot of things, but contributing factors are advanced age, a family history, and of course elevated intraocular pressure, diabetes, hypertension, myopia, long-term use of corticosteroids, and any kind of previous eye injury, inflammation, or infection in the eyes. The incidence of glaucoma is greater in African Americans, in relation to or comparing to non-African Americans. The other type of glaucoma is called closed angle glaucoma, and it may occur when pupils are dilated and the outflow of the aqueous humor is blocked. And it's usually an acute situation requiring emergency surgery. It's glaucoma is characterized by blurred vision, halos around the lights, difficulty focusing, difficulty adjusting to low lighting, a loss of peripheral vision, headaches, and aching around the eyes. Now, the normal IOP pressure is less than 21. The average is around 15 to 16 millimeters of mercury. And, again, anything greater than 21 or 22 is considered an increase. Now, other types of things that can happen with the eyes, of course, is infection or inflammation. And you probably have heard of conjunctivitis. The conjunctiva is the mucous membrane lining around the eyelid. And, of course, conjunctivitis is when there's inflammation there. And, we hear that a lot with called pink eye. Very contagious. It's very common. And it can be caused by allergens, bacteria or viral infections, or physical or chemical irritants. And of course, bacterial conjunctivitis is because of a microorganism, usually staph or strep. It can even be Haemophilus influenza. We usually see with that a purulent discharge. And it can also be, even like a gonorrhea type of infection. If a mother delivers a neonate that has the infection, they can infect the birth canal and the neonate. So you see treatment done for that when babies are born. Um, Conjunctivitis usually involves redness, tearing, itching, edema, and burning, or a gritty sensation in that eye. Blepharitis is a chronic condition or infection of the glands and the lash follicles of the margins of the eyelids, and it usually results from seborrhea or staph infections. It can infect both the anterior or posterior structures of the eyelid and can be painful, as any inflammation is. Keratitis is inflammation of the cornea, and that can result from infection with microorganisms. It can be trauma, allergy, ischemia, and drying of the cornea due to inadequate lacrimation or tearing. It's characterized by irritation and an increased tear production and photophobia. Cornea ulcers may be bacterial, fungal, or viral, and bacterial ulcers most often occur because of infections like with pneumococci or staphylococci. Pseudomonal ulcers are less common. Fungal ulcers may follow topical corticosteroid therapy or injury with any kind of plant matter, such as tree branches and things like that. Viral ulcers are usually caused by the herpes virus. Other fungal infections may often be caused by frequent use of ophthalmic antibiotics and corticosteroids. These ulcers, of course, are painful, and they can cause discharge and change in vision, and swelling, and redness. Now, some other terminology or words to know is meiosis. Meiosis is pupil constriction. Mydriasis is pupil dilation. Refraction is a deflection of light rays in various directions according to the density of the ocular structure through which they pass. Presbyopia is an impaired near vision, which is normal for our aging folks such as me. Normal distant visual acuity is 20/20, and a normal pupil size is 3 to 5 millimeters. And then we mentioned tonometry, which is where they measure the pressure inside of the eye. Okay, so here are our exemplars, and I know it seems like a lot. I guess because it is a lot, but some of these we have already talked about. So we've got the ocular medication classifications, of course, the anticholinergics, which is our atropine, our adrenergic agonist, which is phenylephrine, anesthetics, which is lidocaine, and then we have the glaucoma medications, which is our beta blockers. So you see the OLOL at the end of it. That is timolol. And then we have an alpha-2 adrenergic agonist, and that is brimonidine. And then we have the cholinergic medication, which is pilocarpine. And then we have the carbonic anhydrase inhibitor, and that is acetazolamide. And then we have the prostaglandin analogs, which is the bimatoprost. And then we have antibacterial meds, which is ciprofloxacin, antiviral medication, which is your trifluridine, and then you have your antifungal, which is natamycin, and then anti-allergic medications is cromolyn, and of course our corticosteroids are our dexamethasone, and then we have our immunosuppressants, which is cyclosporin emulsion. So the method of administration most common is topically. So we do eye drops typically, and they can be solutions, suspensions, or ointments. And be sure to look at how to administer these. I know that you probably know that already, but anyway, you want to review that. So instilling drops and ointments, of course, many eye drops or ointments, you know, like everything else, have inactive ingredients, and that can cause, itching, burning symptoms of allergic response. Sulfa agents contain sulfa, and we know that silvasulfidine, for instance, that's a medication that that's used for burns, but a lot of these medicines do contain sulfa, and that is a common allergy among folks, so we do need to ask about allergies. And after inserting drops of ointments, it's not uncommon for people to have blurred vision because it's covering the eye there. And so, it's going to be like looking through Vaseline, of course. And there's a few videos that's posted to go through the administration of that. And also, it's thought that the nasolacrimal occlusion after application, that's where you put pressure on the tear duct there, can help with keeping that medication there. Now, issues related to administration, of course, topical is the most common route, and the correct administration is very important. Systemic absorption can be decreased by occluding that lacrimal duct, and multiple drops, and that's what you usually see with folks with glaucoma. They have several drops, not just one, but they do need to be taken, given some time between the administration of those medications. And absorption does decrease with eye inflammation, so we have to keep that in mind and watch for inflammation, and also the use of contacts. We'll talk about that in a little bit, but the use of that when you put in eye drops should be discouraged or put on hold. So we'll talk about that in a minute. We do have a fluorescent staining that's used, and that can be done to help visualize or diagnose any kind of ulcers or anything like that in the eye. And as you can see the picture there, that's how they do it, and you usually see this done in the emergency setting. And so it's a dye that can help visualize those lesions or foreign bodies to the cornea, to fit contact lens, and to study lacrimal flow of the aqueous humor. And so after they insert it, they'll use a slit lamp or Woods lamp, which is like a black light, and that helps identify that. You usually see this done in the ED when folks come in with some kind of eye injury. Mydriatics, what big eyes you have. So mydriatics are medications that are used to diagnose, because look at that wide area there. You're going to be able to see in there, okay? So, or the doctor is going to be able to see in there. So mydriatics are primarily used for diagnosing. So our first one that we utilize there is atropine. That's what's used. The onset is quick, 5 to 10 minutes. It can last a long time, but typically you see it go away, without the day. Atropine blocks the effects of acetylcholine in the central nervous system, and so that's how it works. It is metabolized in the liver, and of course it produces that mydriatic effect by relaxing the pupil, and it causes that cycloplegia, which is a pupillary, which causes the pupillary dilation. So cycloplegia is paralysis of that ciliary muscle of the eye, and then that results in a loss of accommodation where the eyes can't do that. and you will lose near vision due to the relaxation of that pupil. So again, it's used to diagnose, and it's also used for treatment of uveitis as well. Adverse effects is local stinging, systemic effects if large doses are given. So goodness, we hope it's not used large doses, but it can cause vasostimulation affecting the heart and the bronchial and the gastric secretions, as you know about anticholinergics. Remember, can't see, can't spit, can't pee, can't, you know. So systemic effects like that can happen if it's too large of a dose. Now, it is contraindicated in glaucoma, and we need to teach about that photophobia, so and stinging, and not to go. They shouldn't drive afterwards. Usually, you'll see people with the big sunglasses on there because it's extremely photophobia occurs. So we need to tell them to be sure to wear their sunglasses, and they need to have somebody there to help drive them home after the procedure. Now, our adrenergic agonists are medications for glaucoma, and they are used when the beta blockers can't be used or doesn't work. It's used for open angle glaucoma and ocular hypertension. It reduces the production of aqueous humor and improves the outflow there. Now, adverse effects are pretty heavy duty here with this medication. Systemic, and I always love it when you see this. It's like, oh, really? We can have hypertension, hypotension, tachycardia, bradycardia. Guess what we're going to need to be assessing on the patient before we give this medicine. CNS effects, you can see there, headache, dizziness, somnolence, decreased attention and alertness, and insomnia. Yeah, it can make us drowsy, and then it can make us be wide awake. It's just, it's crazy how drugs do. Respiratory, it can affect, a lot of parts on that. Ocular, look at all those side effects. Blepharitis, conjunctival edema, conjunctival hemorrhage. So goodness sakes, a lot of side effects is what it can definitely cause. And of course, we want to monitor the heart rate and blood pressure and check about any visual changes and burning going on after this is administered. Local anesthetic drugs, lidocaine, quick onset. Now remember, with lidocaine, you do have people that, okay, so it's got the cane on the end of it. So Novocaine, you may have, you should think with that as a anesthetic, okay? It numbs things up, okay? But so you may hear people say they're allergic to Novocaine. So again, we got to look at allergies for this. The adverse effects on this is conjunctival hyperemia, and that is when there's an increase in the blood supply to an area, so you might see really bad bloodshot eyes. It can also cause diplopia, which is double vision. Don't give it if it's crystallized, and we do not need to touch the eye with the applicator, and it's usually not dispensed to patients. Of course, beta blockers are our main meds used for the glaucoma, and notice again we have the OLOL at the end, and they work by decreasing that intraocular pressure. They block the beta 1 and beta 2 adrenergic receptors to reduce that intraocular pressure by reducing aqueous humor production and increasing outflow. Adverse effects, burning, stinging, and there can be some systemic effect here too. It's contraindicated with asthma, COPD, heart failure, bradycardia, any kind of blocks, any kind of left ventricular dysfunction, and of course cardiogenic shock and hypersensitivity. And again, we got to wait 10 minutes between different drugs, 5 to 10 minutes, remove contacts, and wait 15 minutes to reinsert. That's going to be important. Also, drug-drug interactions will be important. We know a lot of people are on beta blockers, and so we don't, we may need to talk to the doctor about, if they're on a beta blocker for their blood pressure or heart, then we might need to use something different here. Um, Evaluating effectiveness would be, measuring that IOP and it being within normal limits, below that 21, less than 21. And of course, we got to teach the client about administration. And we already talked about this one, the alpha 2 adrenergic. So I am going to, one thing I didn't mention there was the MOAIs. You see that quite a bit with drugs in this particular course. And so the MAOIs are, they have a lot of drug-drug interactions. So they need to be off of those medicines 14 days. Cholinergic drugs, the pilocarpine is the drug here, and the ophthalmic cholinergic drugs increases the outflow of the aqueous humor to reduce that intraocular pressure, and it's a quick onset again, and it does cause a loss of accommodation there. Adverse effects, once again, several may occur. Burning, ciliary spasms, conjunctiva, vascular congestion, lacrimation, lens opacity, retinal detachment, myopathy, diminished visual acuity. And then CNS effects can be headaches. Cardiopulmonary can be hypertension, tachycardia, bronchospasms, pulmonary edema, and GI effects can be nausea, vomiting, and increased salivation. So, lots of side effects for sure here. Contraindicated if there is an acute inflammation of the eye, or of course if there's any hypersensitivity, as always. And then administration, there is a solution and gel. So the solution is first, and then the gel 5 minutes later is what should be done, how that should be administered. And then we have the oral or IV dose, the acetazolamide. It inhibits the carbonic anhydrase in the eye to reduce the rate of aqueous humor formation and lower the intraocular pressure. It's used for open angle glaucoma and pre-op treatment for acute closed angle. And it's got, a little bit longer onset than what most of the medicines do because it's given oral. 15 minutes for the IV. The adverse effects, of course, here we see the Steven Johnsons, the flaccid paralysis, blood cells disorder. So let's talk about that. Agranulocytosis, hemolytic anemia, aplastic anemia. Remember, that means that we can't produce any of our major three big cells. The three biggies are RBCs, WBCs, and platelets. We can have leukopenia, pancytopenia, again the big three, and metabolic acidosis. So again, a lot of side effects with these medicines here. We have to look at the contraindications, of course. Addison's disease, electrolytes, hepatic and renal issues as well. And we want to teach the patient about, they definitely need to maintain their lab work, medical appointments so they can get those lab work and intraocular pressure checks done. Need to increase their fluid intake and report any kind of numbness, tingling, burning, drowsiness, visual disturbances, and any signs and symptoms of the electrolyte imbalance for sure. And then we have the prostaglandin analogs. Um, this is their bimatoprost, and it decreases the IOP and increases eyelash growth. Isn't that crazy? Okay, our adverse effects: erythema of the eyelid, allergic conjunctivitis, blepharitis, burning, cataract formation, edema, iris pigmentation, and pain and photophobia and tearing and visual disturbances. And then we have our antibacterial drugs, this ciprofloxacin, and that can help with the treatment of corneal ulcers and bacterial conjunctivitis. No contacts should be used with this until the is all cleared up. The ulcer is healed and the conjunctivitis is cleared. Adverse effects, of course, anybody allergic to Cipro. Also, superinfections can occur, and when it's given with quinolones, we might see hypersensitivity reaction. We might see tendon inflammation and tendon rupture, which is crazy when we're thinking about eye issues and then tendon. So, anybody running should be aware of this if they are having to take that medication. It's of course contraindicated if we got a hypersensitivity, and we need to be sure to not, to teach about not contaminating the tip because of the bacteria. It's going to continue to stay there if they contaminate that tip. Okay, the trifluridine is used for the keratoconjunctivitis and recurrent epithelia keratitis, and that's like with the cornea there, and it's caused, by herpes. Of course, herpes doesn't go away. It's going to stay there. It will tend to always come back, but this is medication used to treat. So it can cause burning and stinging, and it can cause changes in the the tissue of the cornea, increased intraocular pressure, palpebral edema, and stromal edema as well. One thing about this is it does state to store it in the refrigerator. Natamycin is an antifungal medication used to treat the blepharitis, conjunctivitis, and keratitis. Contact use with all this kind of thing going on should be discouraged. You can read the adverse effects there, several of them. It's strange that you got chest pain in there, but it is there. Eye pain, edema, dyspnea, hyperemia, irritation, foreign body sensation, paresthesia, tearing, and changing the visual acuity as well. And then cromolyn. Cromolyn is something that you've read about before or had, and it's used for allergic reactions there, and it can treat certain types of keratitis and conjunctivitis, and the hypersensitivity there is an adverse effect that can occur. Can have eye edema or dryness, irritation, itchiness, puffiness, rash, and tearing, and even styes can develop from this. Now, cromolyn, if you remember, reduces the release of leukotrienes that helps the body's reaction to allergens, and so that's how it all works. And then we have our corticosteroids. You wouldn't feel right if you didn't have a corticosteroid thrown in there, right? And so it, well, of course, is anti-inflammatory, and it's used for allergic conjunctivitis, iritis, and any kind of corneal injury. The dexamethasone includes, when we use it, a decrease in the symptoms of those inflammatory responses that happens. And it's also can be a treatment of corneal injury from chemicals, radiation, thermal burns, or anything like that to help cut off that inflammatory response. It is contraindicated in viral or fungal infections, um, any kind of mycobacterial infection of the eye, and glaucoma and hypersensitivity to glaucoma. And then last but not least is our immunosuppressants. They help increase tear production. They do have adverse effects, as any. And, we with this medication, it can be burning, hyperemia, ocular pain, or pruritus. It is contraindicated with an active eye infection. And again, with the administration of this, we got to, look at the whole contact thing, keeping the contacts out. Okay, this concludes your podcast.